Hi, Assalamu alaikum everyone. Sorry for the delay. I was waiting for Dr. Bashar to make me the moderator, and I'm updating my presentation now. Actually, there is a little problem in the blackboard today. We were not able to connect from our university. So I'm just now uploading my presentation. All right, so let's just start. I've enabled the chat. All right, so just send in a message. All right, good. So you can hear me well, fine. So, all right, anyways, I'm trying to take the class from my iPhone because there's a problem with the university internet, I guess, today. So we'll try to do the best that we can. Today's topic is about interstitial lung diseases. Now, interstitial lung disease is not just one disease. If you look in your book in the respiratory diseases section, you will find a similar term which is diffuse parenchymal lung disease. All right, so it's the same thing, there are different names to it. So don't get confused when if you don't find it in your books. And what we are supposed to do now, many students have a little bit of concern when they are dealing with this because there's not one disease, there are many diseases in this. So we'll just gradually go one by one, and we are going to do the important ones, all right? The important ones in it. So first of all, the thing I've told you already is that this is a heterogeneous group, all right? So it's not one kind of disease. There are many diseases and they are slightly different from one another. Like some of them have a slightly different presentation or a prognosis or a factor that incites it. But overall, they cause the same kind of disease within the lung. Oh, I'm trying to. Yeah. All right. So it's around 15% of the people that actually present to your clinic, respiratory clinic, do present with this disease. I will refresh my browser again. And it is characterized by inflammation of the alveolar walls that leads to slow destruction. Right. So, as I've told you, all right, so thank God the other one is working. I'm going to try to take a pen here. Yeah, all right. So, as I said, diffuse parenchymal lung disease includes a lot of diseases. Now, the first category is those that have a known cause or association, known cause of association. So, it means that when you take the patient's history, you can clearly identify in the patient that this is the reason why the patient developed parenchymal lung disease. Okay, so there is something that is known to cause it. For example, drugs. So, which drugs can cause lung fibrosis? Like, for example, amiodarone, for example, methotrexate. All right. So, a person of, let's say, like atrial fibrillation is taking amiodarone for many years, and he presents to you with fibrosis. You can make a connection that that is the reason. Or, for example, the patient has a collagen vascular disease, like he's a known patient of lupus or sarcoidosis or scleroderma. So that is the first category, all right? The second category is that which is idiopathic. So you cannot identify why the patient developed this. And then in idiopathic, there are actually many varieties. But this is what you should know about, which is idiopathic pulmonary fibrosis. But there are many varieties of that. The third category is that of a granulomatous disease, and for example, sarcoidosis. And this is something that also we will do a little in detail. And the fourth one is the very rare one. Okay, they can't be grouped in certain one specific category, and they are rarer. So these are the four classes of. Um, all right. So first thing is history. So one thing I want to tell you is that this disease is a disease that is diagnosis is based on history, and what we have to identify is whether we can identify something in the patient history or not. Remember, idiopathic lung fibrosis is a disease of exclusion. So you have to rule out other things, and then you can say, well, I didn't find anything in the idiopathic. So your history is focused on number one, what are the symptoms, trying to identify these people, and number two, to try to know if there is a risk for them to develop. So, for example, these are the symptoms. So, you want to ask about progressive shortness of breath and cough. These are the most common ways in which these patients present. Now, remember that unlike patients of asthma, they have a very slow course and a very progressive course. So it's not just that they have symptoms all the time. Gradually, over months and years, they are falling more and more and more. So they will say, first I used to walk like 5 kilometers, then it became 3. Now I can hardly get up. So it's chronically, worsening. Similarly, there are the complaints like cough are also going to be the same. So history includes, like, you have to ask, history of occupation exposure is so important. You must ask about exposure to chemicals. Maybe the person worked in some factory, or maybe he was doing some kind of, like, maybe he was painting. He was a painter, or he was working with other chemicals. So you have to really ask about this. Exposure to birds and animals. Bird exposure can, lead to bird. For example, one of the diseases is bird fancier's disease, and this is seen in people who are like working at bird farms, not just like as pets, but pets can also cause extrinsic allergic kind of disease, but this is more like a chronic fibrosis. So people who are having, farms of birds and they're working with them. Occupation on a broad sense. So we have a few occupational lung diseases. I have some slides. Drug history is important, as I've told you that there's certain drugs that are associated with you. And you have to rule out autoimmune diseases, connective tissue diseases. So you should ask about their, like, what are the common ways in they present? Maybe he has a rash or photosensitivity or joint pain, arthralgias. So you have to rule out those diseases. So history is focused on this. Now, what are the patients? I said the first category was those with known cause of association. So there are some of them that I have written. For example, farmer's lung, I told you, what is that? All of them are, okay, first of all, we can divide them into two groups. Occupational lung disease, number one is category is that of inorganic. So inorganic dust includes the things that are non-living. Oh, sorry, this is organic. Wait. Right. So this is organic, and this is inorganic. Inorganic are the things that are non-living, all right? And these include what? For example, asbestos. People who are working in asbestos factory, silica factory, coal worker, bisonosis. These are all, chemicals. And these are organic things, like people working in farming industry. This is air conditioner lung because of fungus, bird breeder, cheese worker, malt worker. So, that is the reason. You can develop hypersensitivity to some organic material, right? So it can be either of these, organic or inorganic. That's why it's very important to take a history of their occupation. Presentation, as you know, in respiratory, is a very common theme. Most of the patients present with tachypnea and cyanosis. So again, we've done this before. What is cyanosis? The bluish discoloration of the fingers. Finger clubbing is very common in them. This is one thing, interstitial lung disease. The finger clubbing is common. And the second thing is the end inspiratory crackles. And usually they have fine crackles. So these are the things that you might be able to pick up when you are doing examination. Lymphadenopathy and uveitis. Now, this is not in everything, but there are certain, for example, we will come to sarcoidosis in which this is present. Rashes, arthropathy, for example, patients of connective tissue disorder. So, a physical examination will be based on what is the underlying cause of the patient's fibrosis. If a person has, for example, imidazole induced lung fibrosis, imidazole can also cause pigmentation of the skin. So maybe you can pick that up. So you have to do a complete examination. Now, first is the extrinsic allergic alveolitis. This is one of the different. So I told you we are going to do some of these, the important ones. The first one is extrinsic allergic alveolitis. It is caused by inhalation of certain kinds of organic dust. Okay, and I've mentioned the organic dust before. Now, unlike asthma, patients have asthma, right? Asthma is something that doesn't really, that includes complete reversibility and there's not ongoing inflammation. This is an allergic alveolitis kind of a reaction, but it is allergic. So there is exposure, and the typical way a person says, for example, is that I go to work on the weekend I'm better, and when I go to work in the morning on a Sunday or a Monday, I start having these complaints again. All right. And what are the other things? They can have headache, pyrexia, dry cough. Most of the interstitial lung disease you will find are associated with dry cough and breathlessness, and inspiratory crackles, and even sometimes you can have bronchi as well in them. Chest X-ray. Now, I said, I told you that some of the things in each one are different, and you need to try to remember those things. Like this one is associated with organic dust, and inspiratory crackles are there, and the X-ray shows the upper zone shadowing. So, fibrosis of the lung or changes in the lung are in different areas in different diseases. Okay, some of them cause upper lobe, some cause middle, lower lobe, some cause diffuse. So this one typically has a upper zone distribution. Pulmonary function tests for all of them will show you a restrictive pattern. Restriction. Please somebody write in the chat. In restrictive lung disease, what do you expect to find in the pulmonary function test? FEV1 to FVC ratio. What happens to the ratio? Very good. It is high or normal. Excellent. Very good. So yes, it's high or normal. And what are the other tests you can do? Because this is an allergic condition, you can do the provocation test, precipitin test, ELISA testing to identify what is triggering, what is making it worse. So again, antigen testing for this can help you in diagnosis. And as I've said, the same thing. The restrictive lung disease is this one. Okay? This one. This little, this loop that you can see that has the same shape as a normal, but it's just that the overall size has become less. But the ratio remains the same. Now coming on to the next one. Sorry, I have to rush because we don't have enough time and we have another lecture as well. So that's why I'm trying to just convey the important things. So pneumoconiosis is a broad term that we use for occupational lung diseases that are because of inorganic dust. Okay, and amongst them you have many, and one of them is asbestosis. So what is asbestos? Asbestosis is caused because of asbestos exposure. All right. Usually you have, for these you have all of the pneumoconiosis. There's generally, you need a long-term exposure. It's not like extrinsic allergic where you are allergic to it, because this is something that's inert and it's going to take time for the lungs to manifest. So usually a long exposure is there. Then there is a diffuse intestinal fibrosis. So it's not just an upper, it's a diffuse fibrosis. You diagnose it based on history. You have to ask, the patient must have exposure to asbestos. He must have worked in a factory or in a place where there was asbestos exposure. Changes are more marked in the lower lobes. There, it is diffuse, but more marked in the lower lobe. And how can you diagnose? So again, I'm not going to repeat everything. For each of them, lung function test is going to do a restrictive pattern. Okay. What else? What are specific to this? When you do a lavage is that when you do a bronchoscopy, you can take some of the washings from the bronchus. Okay, this is a bronchoalveolar lavage. You put some fluid and you take it out, and then you put it under a microscope to observe it. And it shows asbestos bodies. I will show you a picture of this. Lung biopsy can be done to exclude other things. Usually, lung biopsy is not done. It is only done in patients where you are suspecting that there is a chance of a malignancy. Asbestos fiber count can also be done. All right, so you can actually count the asbestos fibers. So I will give you a picture of that will come later on. Now, asbestos, the important thing is that it is strongly associated with cancer. We did as one of the exposure, one of the reasons for lung bronchogenic carcinoma was also asbestos. But independently also asbestos can cause mesothelioma. I told you yesterday that one of the malignancy of the pleura is as mesothelioma. And it is essentially related with the asbestos exposure. It can be in the pleura, it can be in the pericardium, all right, and sometimes also peritoneum. Sometimes it can also cause just plaques, which are just non-benign scarring, and lung cancer itself. So it is highly, long-term exposure of asbestos is related with increased chances of having malignancy, cancer. We talked about asbestos fiber count. So in the biopsy, you can see these black fibers. If you can see these long fibers, so this is asbestos fiber, and you can detect them in the biopsy specimen. Although this is usually done, when a person dies. Actually, this is mostly post-mortem. But yes, you can see it. All right, the second category we are going to do in the list of pneumoconiosis is the coal worker pneumoconiosis. So a person who is working in the, by the way, asbestos, I forgot to ask, which people work with asbestos? Like in what thing do you use asbestos? Which people are, which industries are they related with? Hmm? Mining, no. Asbestos is used for, we're doing asbestos, not coal worker. Asbestos is used for insulation. When you make houses, inside the house you put insulation. You Asbestos is used for that. Even when you are building ships. So when you're working with wood, because this is a something that gives fire, is fire resistant. So it's used in those things. All right, coal workers, yes, coal worker pneumoconiosis will happen in people who are working in the coal mining industries. And it's caused by, again, prolonged exposure to coal dust. It's divided into simple and complicated. If a person comes before he has developed any complications, simple, otherwise complicated. And all of these pneumoconiosis that I'm mentioning can lead to respiratory failure, and respiratory failure eventually will lead to pulmonary hypertension, and pulmonary hypertension will eventually lead to right heart failure. So this is for all of them. Any patient who has interstitial lung disease over time will develop pulmonary hypertension. And whenever there is pulmonary hypertension, there will be right heart failure. So in all of them, if you do the echo or if there is ECG, it will give evidence of pulmonary hypertension and right heart failure. Okay. And in all of these patients, if you do the arterial blood gas analysis, it will show you respiratory failure. So that is something that it's common to all of them. In simple, you have scattered fibrotic lesions in the chest, but in complicated, there are large masses throughout the chest. Now I'll show you. I think I have two slides. So this is what a cold worker's pneumoconiosis looks like, and this is a complicated variety where you can see these large masses that the patient has developed inside. Okay, so this is a complicated variety. Simple variety, if you stop exposure, if you detect early, you stop, then over time the patient can recover. But there is no recovery from here. Okay, and this is if you on the biopsy you can see all the coal that is deposited. It's a black lung, so you can find it. Again, this is post-mortem. This picture post-mortem. Now the third type of organic dust we are inorganic dust we are doing is silicosis. Silica is what is used, as somebody said before, the cement, for example, industry, and silica is highly fibrogenic. It is very fibrogenic, and it is usually involving again the upper and middle zone. These patients have increased tendency of having tuberculosis, and even when you stop exposure, you can still continue to have fibrosis. So this is something that is different about silicosis. Sorry, this is used in the, I don't know, glass. It is used in the glass industry. Silica is used to make glass. You see all the glasses here. Now we're coming to another category. Remember, we did another category which was the granulomatous variety. Granulomatous variety. Now, in granulomatous variety is one disease which is sarcoidosis. Now, sarcoidosis is a chronic condition and it is a multi-system disease. Every part of your body essentially can be involved. Okay, so you can have lymphadenopathy, you can have lung fibrosis, you can have granulomatous liver disease, chronic liver disease, you can have increased large spleen. In your skin, you can have skin lesions. I will show you some pictures as well. Eyes can have uveitis, parotid gland enlargement, bone involvement. So every part of the body, it can also result in neuropathy. It can cause involvement of the brain. So sarcoidosis is something that is chronic, it is granulomatous, and it has the tendency to involve all parts of your body. All right? Even cardiac, it can result in cardiomyopathy, it can result in arrhythmia, it can result in heart block. If you look at your books, in there is a page of about clinical presentation of sarcoidosis, and they have written most of this what I'm telling you. But how would you differentiate this from TB? Because TB can also essentially present like this. It can present with liver enlargement, spleen enlargement, lymph node. Is on the biopsy. Sarcoidosis has non-caseating granulomas. Tuberculosis has caseating granulomas. This is the difference you find in biopsy. So some of the clinical like skin manifestations I'm telling you, for example, this is erythema nodosum, these red patches that are seen on the shin, slightly raised. So this is seen. Essentially, even for like this is usually seen in female in their mid years. And this is a lupus pernio. Is look at the nose. This is the nasal involvement, disfiguration of the nose that is seen in these people. And this is like I wanted to show you. So that you can see the granuloma and you can see that there is no caseation inside the granuloma. And X-ray is actually, there are 4 categories of X-ray. So X-ray can be anywhere from just having lymphadenopathy to just having limited fibrosis to even having diffuse overall fibrosis. So this one has a diffuse fibrosis. You can see throughout the chest. What are the investigations? So you can do the CBC. All right. You can, in the CBC, when you do, there are some specific things that are mentioned, right? So, for example, you might have anemia, there might be an increase in ESR. Calcium is raised. Now, these are the things that I have made highlighted, are the things that are important and different about them. Calcium is more. ESR, CRP is increased. Serum ACE levels, angiotensin converting enzyme levels can be raised because the cells that secrete this are actually present in the lungs and they're involved. You must do autoimmune screening. Why? Because you want to rule out any other cause. X-ray, now radiological imaging is done in all of them. So you want to do X-ray and HRCT for all of interstitial lung diseases. HRCT High resolution CT scan, as I mentioned yesterday, is the preferred investigation. Pulmonary function test and lung volumes already we have discussed. And on bronchoscopy, it has a specific appearance, and this is cobblestone appearance in the mucosa. And it's very highly specific of sarcoidosis. We do lung biopsy to rule out other things, malignancy or infection. Sometimes patients can present with two diseases, like he's having sarcoidosis but also has underlying infection. So lung biopsy is usually done when you are confused about your diagnosis or you want to rule something out. The good news is that most of the patients have a spontaneous remission within 6 months. All right, and those who don't, you can give them steroids, NSAIDs, and of course, if steroids have to be used for a long time, you have to couple them with steroid sparing drugs. But there is no specific treatment available. The other thing I want to tell is that for all of them, remember that like physical rehabilitation, or in those who have severe respiratory failure, giving oxygen, or those who have right-sided heart failure, pulmonary hypertension, giving them treatment for that, that will be based on whether the patient has involvement of heart or not. So that management will continue. All right, so now we're coming to idiopathic pulmonary fibrosis. So once you have a patient, you've investigated, you've taken the history, you don't find anything, you don't find any risk factor, still the patient has diffuse fibrosis and features, you can label the patient as idiopathic lung fibrosis. All right, and this is chronic, this is ultimately fatal. The thing is, once you diagnose it, usually it progresses very fast. It still has a very poor prognosis. Most of these patients, when they are diagnosed within a few months or a year, they go into respiratory failure, they become oxygen dependent, and eventually, it leads to their death. So there's very poor prognosis. So idiopathic, I've told you, because we can't identify why they develop this, and it's usually between 50 to 70 years of age. There has been seen that it has been associated somewhat to cigarette smoking, but still, it's not. We're not so sure. So just to show you what happens here, this is a healthy alveoli, you can see, and they have space to expand and relax. What happens with patients with lung fibrosis is that areas of fibrosis alternate with normal areas. So this is the fibrotic area, and it is between like this normal area, fibrotic area, normal area, fibrotic area. And this is all irreversible. Fibrosis is irreversible. So eventually, what we find this is it manifests in the form of honeycombing. I will show you a picture of X-ray how this looks like. So what happens is whenever you have fibrosis, there will be affect. It will affect the level of exchange of gases along the alveoli, and this is what happens in them. So you can see this honeycombing. I've shown you a CT scan. You can also see it in the X-ray, but it's not that prominent there. You see these areas, all these areas. This is honeycombing. What is a honeycomb? Honeycomb is, when the bees, uh, when the honeybees, the house of the honeybees, if you cut it, it gives you this kind of a picture, the honeycomb. Sometimes, when you go and buy honey also, yeah, when you go and buy honey also, sometimes they have the whole comb inside. So this looks like that. This is a honeycomb. And you can see the dilated airways. You can see all these black spaces in the middle. You can see fibrotic strands in the middle. So this is how it typically looks like. Even on the X-ray, you can see here there is bilateral, especially lower zone fibrosis. And what else? The borders of the heart are not very clear because of fibrosis. See these borders? They are not very clear. If you remember, the previous X-rays used to be very clear. What is the treatment? We still don't have much treatment. We can just give oxygen. In patients who have this, we can give vaccination to prevent infection, pulmonary rehabilitation, which includes giving them, for example, some kind of physiotherapy, lung physiotherapy. Lung transplantation is what you can do. But if the patient also has heart failure, you can give him treatment of heart failure. You can give him diuretics to release some pressure. And if you want to do transplant, you will do a heart lung transplant in people who have already developed severe pulmonary hypertension. But this is what you can do. And the other thing is that there are certain things, for example, there are some anti-fibrotic agents that have been studied. For example, pirfenidone is one of them. So it doesn't completely cure the person, but it has shown to slightly improve their prognosis, like slightly increase the duration of the, slower, uh, the rate at which the fibrosis happens. So there are some other things as well. For example, we do have some monoclonal antibody therapy and stuff, but that is all, not 100% still under trials. So if you look at this, what are these people at risk of developing? Look at this picture and give me an answer here. What disease can they develop? The people who are working here. Coal worker pneumonia. Excellent. So I think, I've taken some classes. I think this one whose number finishes with 03 and 17, they are usually the one who are, the same people who have answered today are the same people who answered in every session. So at least I hope that you guys remember some stuff. So it's a bit difficult topic, but remember the only things that are important I've already told you. These were the important things within this. Go back to your books, read these ones. You don't have to read through all the idiopathic lung, idiopathic diseases of the lung. Just from the diffuse parenchymal diseases, the ones that I mentioned: extrinsic allergic, idiopathic lung, pneumoconiosis, and sarcoidosis. Go through that. If any questions, let me know. I'll see you back again in 10 minutes. We are having some problems with Blackboard, but hopefully we'll get back. Okay? All right. Thank you. Yes?